Leuven used to be a very important city in the medieval times, and this is the old city hall. It's in the same style as the Brussels City Hall. This is the university library, and on the inside it's very beautiful with wooden library shelves and chairs where you can sit. This is the research building where we work, and this is the old market, and this is the biggest outdoor bar and restaurant area in Belgium, very popular with the students. And Belgium is between France, Germany, and the Netherlands, and we are just 15 to 20 minutes outside of Brussels. So the stomach is a topic that is near to my heart, literally as well, and it has a number of roles. It is a storage of a big meal, of a smaller meal, but especially a big meal, and it initiates digestion with pepsin activity, and then it has a controlled release function to the duodenum at a rate that would match digestive and absorptive function in the duodenum. And together with that, the GI tract constantly signals to the brain whether or not nutrients are in the upper GI tract, how many there are, what their main composition is. So this all related to food handling plays a very important role in our hunger and satiety signal. A couple of other functions. Gastric acid is a defense against some of the infective gastroenteritis. Some of the microbes we swallow die in gastric acid, and it is also actively involved in the absorption of vitamin B12. If you see a cartoon of the stomach, a drawing, it looks like the one in the middle. But actually this is not correct. Upon fasting, the stomach is completely contracted. And it's a small volume, 100, maximum 150 ml, a little bit of liquid and some swallowed air. And if you start eating, there's an active expansion that we call accommodation. It's an active relaxation, and it can reach up to 1.5 liters content easily. At the same time, gastric acid secretion starts, and you have a switch in peptide hormone secretion related to the sense of feeling that food comes in and satiation. And there is perception as well linked to this. And then the next phase is the emptying phase. And the food will come into the duodenum, acid will come into the duodenum, you will get duodenal bicarbonate secretion, you will get a different array of peptide hormone secretion, and you will get more detailed sampling of the composition of the meal in terms of macronutrients and micronutrients. And there is perception now of having eaten and being satisfied. Now this can go wrong. And so you can have impaired gastric accommodation, you can have delayed mainly emptying, and you can have visceral hypersensitivity. And what this does actually is induce symptoms, usually with every meal. And these symptoms are not lethal, but they are debilitating because they take away a lot of the quality of life. We eat 3 times a day. And each time you eat, in those who have symptoms due to these disorders, the symptoms are triggered. Moreover, eating is very, very important socially. The perception that we have, the well-being after a meal, is socially bonded. This is why families eat together. This is why businessmen, when they conclude a big transaction or contract, have a dinner with their client. This is why dating involves going to restaurants, and this is, if you travel abroad, the people who receive you serve you their national or regional specialized dish, and you're supposed, and you do like it. And you lose this if this system is bothered. I read yesterday an article in The Guardian who actually looked at the rankings of happiness in the world, and the ranking of happiness did not completely correlate with wealth. And the distinguishing factor was to which extent people ate together. In rich countries like the US, where people abandon eating together, happiness is going down. Of course, Scandinavia, everybody is rich, and they're very happy, they're at top of the ranking, but they eat together a lot of the time. But South America, socioeconomically lower rank, is happier than you would expect based on income, and it's attributed to eating together. So which symptoms does it get? Well, you can talk to patients and discuss the symptoms, but if you start doing that, once you explain the second and especially the third symptom, the patient will think, hasn't he asked this before? Because verbal descriptors are very similar and sound similar to people who have less abstract thinking and vocal ability. So that's why to select patients for studies, for screening for studies, to evaluate presence and severity of symptoms, we use a waiting room questionnaire, which has a verbal descriptor with pictograms. And this is the pictogram where we show where gastroduodenal symptoms are felt, between the lower end of the sternum, the umbilicus, and the midclavicular line. We have a paper in press, like later this month, actually showing that if you use this, the concordance with a very, very in-depth, detailed physician interview is 70%, and with verbal descriptors it's only 30%. And then for the symptoms themselves, a picture says more than 1,000 words. This is how we depict postprandial fullness. This is how we depict early satiation. And if you describe these, it sounds similar, but the picture really differentiates it. Epigastric pain and epigastric burning, look at the location of the flames, but they are self-explanatory. And these four are actually the cardinal symptoms of functional dyspepsia according to the Rome consensus. Only 4 symptoms. And if you have these symptoms, long enough, severe enough, you have dyspepsia. You have uninvestigated dyspepsia. And the Rome consensus says if you want to be sure that it's functional dyspepsia, you need to do an endoscopy. And it was estimated that 70% would be negative, so that would be functional. And the other 30% you would have a organic finding like peptic ulcer disease, gastroesophageal cancer, or reflux esophagitis. Now this number is largely driven by Western societies' findings where you have a lot of reflux esophagitis. If you do this on a global scale, this is a meta-analysis of 2 years ago, actually 82.5% of the endoscopies is negative. And if you find anything, it's mainly reflux esophagitis and peptic ulcer disease. And fortunately, gastroesophageal cancer is rare. So the vast majority of uninvestigated dyspepsia is functional dyspepsia if you would investigate it, which you don't need to do in all primary care patients. So you can do a survey using questionnaires without pictograms, unfortunately, on a global scale. And this is what the Rome Foundation did, an online survey in 25 countries, people representative for